What's the speaker talking about tomorrow?
KST technique.
Or what's he talking about?
And he's probably might talk about AK some, like a different kind of technique.
Oh, you told me that. Never mind. I forgot we had this conversation. Bless you.
Very interesting to watch.
Yeah.
So I wouldn't.
Is there a test for sharing?
Well, the classic AdSense writes as a pulse.
And that would include
It would include that there's something. There's your law. See, there's your pulse. Yes,
Do you have a test?
you're losing pulse.
I'm just curious. Yeah, we were doing this morning and I was like, I know, I was like, I was just wondering if you had a test like this. No one ever does. I don't think so. You didn't have any napkins. Tested with it. Yeah. Yeah, exactly. This is not my napkin. Maybe. I like your bag. Oh yeah, where's your cup? Yes, in my bag. I finished my coffee already. You have everything inside. Literally all the coffee. What do you have in the notebook? Yeah, it's sitting there. You want it? No. She literally just said,
Did you try what actually?
I just felt weird.
Mine was done. I tried. For science.
You know what this is?
I was gonna tell the truth. Oh gosh, I probably won't get it. Is it like a joke or something? Okay. It's okay. So like if it's some kind of joke, I probably won't get it. Oh gosh, okay. Did you show me that? Oh my gosh. If you have TMJ. I don't see why not. It's kind of confusing. It's a professor, kind of. Yeah. Probably not. It's like low key unsafe. It's like, yeah, but. You're so dumb.
So we're gonna.
Exactly.
Just like something else.
The bottom?
What is happening?
Oh, I see hot.
I see. Oh my god. Honestly.
Yeah, that might actually help.
That's crazy. I see hot.
I would not prefer that probably.
No.
But I feel like, I don't know, I have sensory issues, so. Yes.
Definitely better than everybody's invited to do this. Yeah, he has me anyway.
Yeah. I don't know, maybe. I can't remember, but I know it's familiar. Come on, remind me, I know it's something I see. It's a type of weapon. Okay, so it's like it's a lot of that.
I know, like, you know what?
I have a super like someone is switch. It's just the cross call that you do, or you define it positively switch.
I was just going over these notes because Switch confuses me so much. It could be.
Can it be both?
It could be literally anything they're talking
Yeah.
about. It could be a supposition, a fixation, it could be mental, it could be emotional, it could be,
Yours was just the cross crawl.
Yeah.
I mean, I guess you could like start with that.
Yeah, and if it doesn't fix, then you can
Then
say
you want to radical.
or dehydration. Switching always confuses me.
Because you're switched.
That's why I say, Al, get up there.
You two guys were, remember you guys last year, have you, anybody tested that on you since then?
I did it for a couple days after and then forgot about
Yeah,
it.
I mean, it's a cumbersome technique, but it's really revealing. So, hey guys, let's,
It's target
I think we're mostly back. We're gonna start with.
I feel like such a mom. Oh, it's an old baby.
I need my patient.
Oh.
So, now, we talked a little bit about this stuff, anterior cervical disc, brachial plexus stuff. It all kind of ties in with thoracic. Thoracic outlet means anything that can interfere with the nerve roots exiting the cervical spine, and then the meshwork of nerves that they trade back and forth with until the single nerves get into your arm and your shoulder. So anything that messes with that brachial plexus is it's a thoracic outlet kind of thing. Now, a classic thoracic outlet is when you do things like the Adson's, Edens, and Wright's test and look for pulse changes as you go up. That would lead you to possibly a first rib interference with the arterial supply in the arm. But you can also, we were just talking about this, you can also muscle test in that position too. You can actually muscle test the hand. I know a lot of AKers do that. I'm not a huge fan of that, really. I think the old-fashioned, we were just checking Erin's pulse, and she's pretty good in this position, and then we start to lose it right about here. And honestly, that's probably as accurate or more accurate than a muscle test. Where this starts to diminish, and then this is even less, and this side over here is fine. So if that was TOS. See, that's good. And we did suspect a first rib. What else, like from an AK perspective, what might we suspect from that? Kind of say fixation, for example. Limbic fixation, right? C7T1 first rib, which will cause what? Besides maybe thoracic outlets, ankle muscle weakness. So because she came to me, or we started talking about it, and she has trouble with her neck staying in, right? And you have trouble with the shoulder. I thought maybe I could go through and check because she's been adjusted, she's been fiddled with quite a bit. And we just cleared another glabella. There was a little deeper glabella, I think, but she got fixed earlier. But I want to go through and test pulse points, TS line. We could check posture, fun, and cranials to see what else. Because like when somebody keeps coming back, yeah, my neck never holds, then it's time to look at it. It's time to look at other systems. I want to do that next. And it's just to kind of finish up the shoulder thing. And then you guys, we want to have all you guys test the shoulder muscles. Did we? We didn't. We went over them. We haven't done them. All the new ones. And yeah, we might. I think then we'll hopefully have some time to do. I wanted to do some review too and do sample questions for the exam. Hopefully do that in the last half hour, 20 minutes, something like that. That'll make everybody stick around for the end and give away some of the questions. So anyway, this is what we've got right now. Go ahead and stand up for a second. Let your back to the crowd. See if you see anything notable. Right shoulder a little high, right? Nothing earth-shaking. Earth-shaking. In this thing. Pretend nobody's looking at you. You do have a bit of a, pretty pronounced lordosis in your spine. Kind of, it's part of your architecture. So nothing really earth-shaking. Now with that high shoulder, pull in here. Got a weak lat, which kind of makes sense with what we see posturally. I'm going to spindle down the trap. This is session 1. Think of session 1. I go in here, just spindle down the trap. That turns on. Spindle back up the trap. So there's a direct relationship between lat and upper trap. So that totally fits with posture. Let's head to laying back. Actually, can we switch you? Because I'm kind of better on the.
We can switch that table.
Let's just switch. Yeah, we're going to do that. Yeah, I don't know if you have that up on your computer.
Oh, that one actually moves.
Mechanism. Pillow's good. So I'm looking at leg length. I don't see anything out of the ordinary. I don't see anything glaring with pelvic stuff here. We know we have a shoulder neck issue. Push. That pec is weak. That one is weak also. External weak. Sorry. I popped a little bit. External. So we got some, yeah. Okay. When you get several muscles on both sides of the body, you can chase down each muscle, but when you see that, you start thinking something. Start thinking something's going on at the core level. So what? If I had an assistant in the room with me, they could do a gentle traction on her neck.
Yep.
Gentle traction.
All gentle traction.
Gentle traction. See how that turns on. That's just taking pressure off. Now, there's some traction on there. If I go in here and touch the vertebrae again, it goes big again. You wouldn't let the traction off. That's just one way to approach it. If you have an assistant, there's a seat. Now, if this comes back. Now, so we checked to see what traction turned on the muscles. Now, let's see what having you take a deep breath, hold the breath, punch, breathe in through your mouth. Not much, okay. Out. Good. Half breath in. Full breath in. What am I checking for? Half breath out. So none of that affects it. So I'm not going to go chasing after cranials, not at this point. So what about TS? Well, it's kind of hard to test these muscles and have for TL and TS. So I'm going to use a leg muscle. We'll just do a quick scan of the TS. That's good. Now remember, we have 4 groups here, here, here. Start again. Oh, then we got something. Let's go get started. So, just got an upper thrust. T2 or 3. Which will address at some point. So we know that. So there's about a T2-3 fixation on the right. I can feel it. So we have that. Now we'll go through the rest of the TS. Just do all of them. The top ones. That's good. Now come back to just fast forward. I'll do the other side. Interesting, the fixation is on the right. Something there. Yeah, that's the guy. Yeah. That's clear back. That's a lower thoracic. It's going to be right about there. Now I can't feel much there, but if I do a quick test, that's weak and there. Okay, so right about T8, T7, 8, which would match up with that. She's got a thing, and that turns on the head. So I found 2 things. I found 2 vertebrae that I might not have found otherwise using TS. Are you with me? And I'm just really anxious to adjust things, but I'm going to hold off, restrain myself. Let's check the postmarks. So if somebody write this down or remembering it, so I don't have to. We came in, we had weakness. Somebody's writing it down. Everybody, each person remember one thing. So we started with, to kind of back, we started with, she had a long head tricep weakness. And we were also doing the TOS test with the muscle test and also the pulse test. And the pulse showed consistent positive. The muscle test was kind of like a big spag. Yeah. So what really helped was this position. It was like flexion with right rotation. So like we had with Jennifer, where she was, I think she was more this way. right, you were like there, yeah. You get that, yeah. And then D, we had to do adjustment on your anterior there. Okay, so far we know you've got a T3-4 and you've got a T7-8 left and right, right and left. I must be switched. And C3 we do that. So we know about that subluxation wise so far. Now let's check your meridians. And we know you got a weak lat. Your left lat. Right lat. So there's something that those never usually come up. No. Deep. Deep. Light. So, small intestine. Small intestine is tricky because then I got to find a different. Yeah. Okay. So what am I testing? Quads. Oh, David. So it is central because both of them are weak. I want you to go to your. I know we went in on the meridians, but I want to also check this is the Chapman reflex in the anterior for the quads. That doesn't do it. Okay, so then we're going to go to the alarm point. Remember, an inch below the belly button is triple warmer. An inch below that is small intestine. The inch below that is bladder. So we want to go small intestine. And swish. Okay, and we got lucky. Swish. What's that? There? Really? Now, so the alarm point strengthened the quads. You know that? Now, the vertebral levels we have are C3, T3-4, and T7-8. The T7-8, you're getting down into like liver territory. T3-4, you're talking in the metric system, you're talking gallbladder, but you're also talking pericardium. That's where the associated points are. So I'm just thinking out loud. But our main problem is the shoulder and this TOS thing going on, and the neck not staying in. So I need to determine, after we're going to check IRTs, but I need to determine what I'm going to treat first. And do you have trauma? Did you have trauma?
I
Fell asleep. Fell asleep. No, you didn't.
got married.
Oh.
Two
Arm
scared
falls.
balls.
So you got her. What was that? Very recent. That's the.
But this would be just gonna work.
Gotcha. Now, we want to test and see if there's an IRT pattern going neck or in the shoulder. So when I find this weak muscle, and I go in here and I spindle up, you have to spindle up both the lateralis and the medialis when you do it. And it doesn't strengthen. What does that tell me? If a weak muscle that you find in the clear doesn't temporarily respond to AF, autogenic, what does that indicate from yesterday?
An IRT.
IRT, injury recall. That's how you know you got an injury recall somewhere in the body, because the weak muscle that you went in on, which in this case is the quad, you could also check the lat, pull in, see the chest. Now, I'm gonna go in, the lat's a little tricky to spindle up because there's a lot of it. Usually to get right in kind of the middle of the bulk of the muscle. That doesn't test either. So we got an IRT pattern affecting these weak muscles. We don't know, is it the neck from the car wreck? We're not sure, but we know that's one injury site, one previous site of trauma. Anywhere else you've had trauma? So what area? Actually, you guys hear all that? So we get plenty of, so we could take our pick. So, first area would be, you said L3? No,
Fractured L3, L4, and then that didn't get fixed for about a year and a half, so it didn't heal correctly. And then sacral plexus compression that caused me to.
so I'm gonna stimulate that area. And that doesn't, so I'm gonna go a little lower. And what I'm doing is I'm just basically poking it, shaking it, trying to stimulate as much to bring it up on the screen. And that does change it. That's pretty cool. We'll let it sit because we haven't fixed it yet. We haven't fixed the IRT yet. Let it sit for a bit, let the weakness come back, and then we'll check it in. Because we can, you can have multiple IRT patterns. Sometimes the IRT patterns don't even get it. Yeah, so that comes back again. Now I'd like you to just touch your mid neck, your mid C3, 4. And that doesn't seem to do much. Now, we'll just kind of make sure we're making that up there. So that's not an IR pattern. Low back is, right at the sacrum. Now, a lot of times, sources of IRT patterns, which are old trauma sites, sometimes they don't TL in the clear like a regular subluxation was, or would, or another type of muscle injury or something, because they're that part of it's healed. So sit up for a second. And so I'm going to have you TL right at your sacral base. See, that does TL. So we do have. I believe it's an IR pattern, but there's also something else going on. So let's do the IRT first. Lean back again. So make sure you guys are with me. I'm going to do IRT on this area, right at her sacral base. So what should I do next? We've determined that she has an IRT pattern there. It's affecting these quad muscles. So it's the lower part of the body. It's below T6. So what would I do? IRT.
Stimulate it, wake it up, and the talus.
Everybody agree with Dean? What he said.
I don't know.
Yes, you do. You guys are amazing. Right there, somewhere. Jostle it. Really want to get the brain's attention. And I want the brain to plug in and or get that aberrant tape running so I can hopefully get it to just dissipate. Now, a lot of times you'll see people doing IRT and they're not as, I tend to really get in there and shake things up, and I'll do it several times. Not everybody does that. Sometimes they kind of go rub, 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 click, click, and then you watch Kerry McCord do it. He's really slick. That doesn't mean he doesn't at times do it really. Okay, so we see if we got it. Now the muscle turned on. Sometimes the muscle doesn't turn on. We had one yesterday, but it does then autogenically facilitate. In this case, they did turn on. Let's see what happened to the lat. The lats now touch your neck again. One hand, left. So we still have to address that cervical. There again. So she still got that. So the IRT didn't fix that. And just to be double, triple sure, I'm going to go in and spindle up that. And that pec wants to turn on, so I don't think there's an IRT. No, it turns on temporarily. That's it for a little bit. So we are going to need to address the mid-cervical. Now, we don't want to forget the meridian. Because we had quads weak, and we had the small intestine meridian. And the quads did strengthen to their alarm point. Small intestine alarm point, remember? Now, where is the associated level of the small intestine? On the bladder associated points. Where is it for the small intestine? S1. Sacrum. Where is her IRT? Where was her injury? That where we found subluxation. So that ties. I just realized that as I'm thinking this out loud. That really ties in. Small intestine meridian showed up. Most points. Small intestine related muscles, quadriceps, which strengthen to the alarm point. And then also the IRT pattern was at the same. And she has a history. There's a history of injury there. You are consistent. You are. Now, what about this though? Is this lat still weak? And this heck is still weak. Go back to your small intestine. Just before I leave that and go on to something else, I want to see, does that alarm point, by some weird chance, strengthen heck? And it does. Did you guys see this? That turned on. That turned on. Weak lat. I need to treat her small intestine meridian, which also involves going down into the sacrum to address the associated points. Does it? Okay. So is anybody, now there's some needlers in here. Does anybody want to needle her small intestine 3, or are you comfortable with that?
Go for it, it's gonna hurt.
Anybody?
Everybody wants to do
A
it.
bunch of needlers.
Let's all do it.
Like Kayla should do, she's the TA, trust me.
Okay. Whoever's got a needle and gets up here quick.
Oh.
Because
I need yourself put one in there.
Let me address the sacrum first.
15 needles. Oh, clear that channel.
So, guys, I'm going to adjust her sacrum.
Okay.
And then,
I know, it's so easy.
so I'm going to adjust her sacrum to address that associated, because that's what I challenged her. And then Kayla's going to put in a needle in small intestine 3. Let's do both of them. Do both sides.
Okay.
Okay. Now we'll see. sacrum, I like adjusting sacrums. That's a challenge. All right, so do you want to maybe go over to your table there and she can, Kayla can put us that way.
I mean,
So bad. It's fine. Oh, cool.
Yeah, so like,
Somehow.
it's that for reality. I know, it's not yet.
So just to run over these slides quick, you guys.
plastic outlet.
You know, according to Craig, it doesn't matter anyway.
Just to run through these, so hidden cervical, when you see thoracic outlet-like symptoms, including positive acidines and or rights, paresthesia, one hand colder than the other, all these different kinds of things. When you see that, these are some of the structures you want to start thinking first. First rib, of course, classic. Clavicle, the clavicle might be, laying back this way too much. If you've got a weak pec minor, then a lot of times the rhomboid will actually pull this shoulder complex back, and now you've created an ischemic potential right there where that clavicle comes. So, you think pec minor. I don't ever overlook pec minor. I have had patients cancel their carpal tunnel surgery appointments after I fixed their pec minor. That happened several times, not just once. Pec minor was causing
Everything in the
thoracic outlet syndrome
It's okay.
can often show up as carpal tunnel. It's like the double crush phenomenon. If you've got 2 or 3 places along the course of that nerve that are being impeded, it often will show up maybe as carpal tunnel. Then, symptoms. And then you'll see, I've seen this many times in practice, people will actually get carpal tunnel release surgery, and eventually the carpal tunnel either doesn't go away or eventually comes back because they had a problem with several other places along the course of that nerve. And that carpal tunnel was not just one of them. So pronator teres, which will go in the next session. Pronator teres often can interfere with pronator quadratus, pec minor dysfunction. So that's the kind of stuff you want to think from an AK perspective when you run into TLS. Clavicle first rib, anterior scalene, of course, we found with several people had scalene issues. And pec minor. Now test the pec minor the way I showed you guys. There's some other ways of testing it. One in the blue book is, you can use those tests, but honestly, you'll pick more up this way than you will, in my opinion. It's just like the long head tricep and the long head bicep. There's the classic way of testing it, which is a good screen. But if you're really suspecting there's a problem, you're tested long lever, long head this way, you'll pick up stuff. And same with the bicep. You test it out here like this, you'll pick up weakness that So this is kind of the, this is a misprint last year. I had to go through and fix this. What was our guy, David? The other guy in the class last year, the first session class.
Sure.
Who sat next to you?
Oh,
Bobby?
Bobby. David. Bobby.
That's
Bobby.
close.
Yeah, Bobby was the one that pointed out there was a misprint on this slide. He goes, isn't that like, right? So I had to go back and fix that.
That's Bobby.
This is the generally well-held muscle involvement in shoulder abduction. Your supraspinatus is what initiates abduction. That's why we test it right at that range. And then you've got deltoid really kicks over. Now we're not talking a flexion abduction. We're talking just straight abduction. Deltoid really kicks in through a long range. Then you've got supraspinatus Again kicks in, serratus starts to move the scapula, upper trap. From about here up, now you're moving scapula. From here up, you're pretty much shoulder. Here up, it's now scapula. At the very end, you're actually, to get clear up like that, you're actually moving your. So that's muscle involved. So when you're testing it in abduction, be very, very aware of what the dominant plate is. Now, the classic shoulder tendonitis bursitis is, they're like, that's as far as I can get. A lot of times it's a supraspinatus problem, and they can't get it up far enough to where the deltoid can take it. A lot of times,
Do they like,
yeah, they'll help it. They'll go, yeah. And sometimes these people will be able, sometimes these patients will be able to come up pretty good this way, but as they come down, it's like, whenever that bursa, if the bursa is inflamed, the subdeltoid bursa is usually the most common one that flares up. When that bursa is inflamed, a certain amount of pressure on it causes intense pain, and they just drop their shoulder. They used to, when I was first in practice, or years ago, it wasn't uncommon to see people being put in slings. These conditions, shoulder tendonitis, brachial plexus stuff, any wide variety of things that involve shoulder pain, they'd be like this. And that's the perfect recipe for adhesive capsulitis. Now they don't do that. Get that, and my patients come in and they're like, hey, I want you moving that shoulder every day, every half hour. Take it and just use your other arm. You don't have to do it under your own power because it's too painful. You've got to keep that, or it will adhese. And once it adheses, then you've got adhesive capsulitis. And that can be a mild version all the way up to something where they're like, this is it. And those are very hard to deal with. They're really hard. So if I can catch them where they're just kind of like that, a lot of times I can fix them. If they've been like this too long, a lot of times I can't. Serratus anterior is one of the key muscles for shoulder dysfunction. A lot of times it's overlooked. Most people don't know how to test it properly. They miss it. And if the serratus is shut off, that means this whole shoulder complex is just always kind of like cocking and shifting and creating all kinds of havoc for the muscles that are attached to it. So it's like trying to fix wire up a lamp standing on a trampoline. Anyway, so that's our range of motion, passive range of motion. Subclavius is often something you'll find weak, and who had a subclavius that we spindled up? Was it you?
Oh, I didn't know.
You did, that's right. Make sure somebody test that again. See if it holds. Serratus anterior, spondylogenic, that's, we haven't really got into that yet, but. You'll often find pain through range of motion. That is common with spondylogenic subluxation, but it's also common with reactive muscle. A couple sessions ago, for reactive muscle. Synergist that is overactive, helping out its cousin, and then it develops this abnormal proprioceptive pattern of having. Reactive muscle, and it usually needs to be spindled down. That's the typical treatment for reactive muscle. It is a reactive muscle, but it's the typical treatment for it is reactive muscle. Yeah, for reactive muscle. I think my terms confused. So a reactive muscle is going to be a synergist overreacting to its cousin's weakness. But once you fix the main weak muscle, a lot of times the reactive muscle will still be interfering with Anyway, deltoid is a big mover. The lat's a big mover, upper trap's a big mover, pecs are big movers, rhomboids are big movers. But the real refined management of forces around the shoulder is going to be the supraspinatus, infraspinatus, subscat. Orco, I think, is a really important stabilizer. It's not a very big muscle. It's often injured. Anyway, this is just saying the same thing here. You get that full 180. You've only got about you've got about 100 degrees of actual spinal-humeral abduction. The rest is going to be all scapular motion and eventually last spinal. So shoulder muscles, I think we went over this yesterday. This is, always think functionally with the shoulder because they're really different categories of muscles. You got your sits muscles along with these guys, which are scapular and humerus. And then body to scapular clavicle, and of course, spine all the way to humerus. And there's only two of those. Pecs, three if you count two pecs. And I think those aren't the others, right? No. They go from the body straight to the humerus. Big, long territory covering muscles. So anyway, I don't think, does that make sense? I mean, you have to think of, there's so many different muscles going all these different ways in the shoulder that you have to kind of like think about which group you're trying. This is just ad nauseum, some anatomy stuff. It shows the, can't read, these are so fuzzy. Here's the pec major, its attachment. I'm looking for the, here's the subclavius, it attaches here. That's not a very good slide. So, this is worth looking at. This is a quick reference for if you've got a weakness of the subclavius. The joint you're kind of thinking about, you may want to challenge or address would be the sternoclavicular. Deltoid upper trap, acromioclavicular. Serratus, inferior scapula, and Dr. Francis says scaphoid. I think sometimes wrist subluxation can cause some of these muscle weakness. Anything rotator cuff, any of the rotator cuff muscles, you think about the actual GH joint. Slip bicipital tendon, but also, which is much worse, is a slap tear. Worcobrachialis, acromioclavicular, dislocation of all muscles weak, or compaction, except for one like we had. We had the long head. Oh, Jennifer had the long head. Who had that? Oh. Yes, you had the long head bicep. Yeah. So all of these conditions are things you'll run into. Conditions and or components of injury, like adhesive capsulized trigger points. But no matter what they come in with, just fix what you find. You know how to test, or you practice will know how to test each muscle that moves, that accounts for all of the function in the shoulder, stabilization and movement. So regardless of what name has been hung on the problem, you can determine what components need. And a lot of times these conditions, they're a sum of many parts. You don't just get bursitis in one shoulder out of the blue. And you might get bursitis in both shoulders and both hips if you're really toxic and you're eating a lot of food that's pro-inflammatory. But if you get one bursa inflame, you've got local problems of that, how that shoulder, how those structures manage forces come through them. Rotator cuff tears, lots of information out there on those. A lot of them heal with the right kind of muscle rebalance, right kind of exercise. A lot of them do recover. If you haven't disrupted too much of that matrix, that connective tissue matrix that makes up the cuff, and if the person's a good healer, if they're getting enough protein, if they have enough vitality, if they're getting enough nutrients, a lot of cuff heals, cuff tears. Just like ankle sprains. I mean, bad ankle sprains can recover very, very well with the right. Often they don't get the right kind of care. They hobble around until they heal up, and then they take their ankle and they go back to doing what they've been doing. And that's often, that's often how you end up with a ankle or shoulder. A lot of tears go on for years before they become enough of a problem that someone goes in and actually has them diagnosed. And the only way to diagnose a tear, nowadays they use MRI. They used to use dye. I don't think they use dye studies. Maybe they do, but I never heard of them using it. Where they inject and then X-ray it. But now they do MRI. The MRIs are really good. Tears. Barely see people going for shoulder surgery nowadays. To see, probably see a fifth of what I did. A lot of injections. They love their. Now, can you guys inject steroids? Yeah. All else fails. They're very effective. So with any joint in the body, this is one sort of flow chart you can start thinking about. With any joint, you think about alignment. You check it for alignment. You check it with palpation. And then you think about the nerve supply to that joint, or to the muscles around that joint. So when we're talking shoulder, elbow, wrist, we're really thinking about brachial plexus. So have that in ligaments, the muscle itself, ligaments, anything local to the area, skin scars. We talked about adjusting skin scars. Pressure on that yet? What's that?
Laser.
I don't feel like we
I don't think you've gone over
People
scarring.
that do it, but I'm not mean with laser. I mean, I use just do like a traction, the same way you would treat a cranium. Or and the only time I would mess with the scar is if it number one, if it TLs, or if it's right over a meridian. Sometimes a scar can disrupt a meridian, and then it's worth seeing. A lot of times you just put a little oil on it and just kind of work. You're trying to disrupt the cross hatchings that are holding that tissue from being as flexible as it needs to be.
Have to sound permanent.
Oh, sure.
Yeah.
Yeah, those scars can really respond well. If they, and it's always worth a try. Then, of course, there's always the IRT. Anyway, this is just one little, I think this is from Dr. Tim's bursitis. A few words about bursitis from a physiological perspective. Bursitis is, what happens is the synovial fluid is too thick. And the exchange between fresh fluid and the resorption of the old fluid gets thrown out. So the fluid sticks in there and gets thick. And then, of course, it loses its ability. Good. cushion and facilitator of movement. These tissues, remember, have a real high turnover. The category of tissues that line bursa and joints and it's called glycosamino gangs. You guys are off. So that family of tissue types, super high turnover. But glucosamine sulfate, chondroitin sulfate, keratin sulfate, those are all part of that family. So they're high wear areas and they're sulfur dependent. They are, if you disrupt the regular maintenance and repair of these tissues, then you start to have problems. They just don't work as well. Then you get stiff. And then if it causes enough disruption, the immune system gets involved in inflammatory event, and you've got bursitis. So when you look at someone who has consistently developing bursal or tendonitis problems, you want to look at their sugar intake, look at their fat intake, and of course their overall digestion. A lot of times everything they eat is amping up their inflammation. They're eating bad fats, which are promoting pro-inflammatory prostaglandins. You guys know that. So you got to really look at the diet. If their diet is like what I had last night, fortunately I didn't finish them. Deep fried cheese curds. God, those were good. But that would be just fast track. Something like that. I didn't eat all of them. I ate a few of them. This is not. But in the meantime, wow, they were good. Yeah. So anyway, so it's not enough to just ice it and rest it and wait for it. You really got to look. If you really want to help your patients, you got to really look at what they're not eating, not supplementing with. Ileocecal valve. A lot of times you'll see widespread inflammatory activity in the body, chronically open. If they have a chronically open ileocecal valve, they're chronically inflaming their gut. And so that's kind of this for that, slam dunk. Ice, sure. NSAIDs, I'm not opposed to NSAIDs short term. I don't know what you guys' positionality is on NSAIDs, but seems to me if people use them, they can be so incredibly helpful if they use them for say 3-4 Advil or whatever. And I've tried some of the humanoids stuff. Vioxx makes it's called Caparest, NF-kappa D blocker. I think those things are great, but you got to take a bunch of them to get anywhere near the same result as Advil. That's just what I keep finding. I unfortunately have a lot of patients who are on too much Advil, and the way it's marketed, you think it's vitamin or something. But it was explained to me once, and this kind of resonates with me, because so what do NSAIDs do? They disrupt sulfur metabolism. The very thing that it can lead to plain bursa and tendon sheaths is a disruption of sulfur metabolism. So they're actually adding to the problem that led to the tissue breakdown. They're also hard on the gut because it's important for gut rebuilding. So, but if you only take them for 3 or 4 days, if that's enough to knock the inflammation down so you can get back on track, to me that's much, much better than just being inflamed at a time. That's my thinking. So I'm much more likely to suggest to my patients that they try, especially if a lot of my patients, they don't want drugs. They don't want any drugs. They want everything natural, which I understand. That's why they come to me. But I'm like, Sometimes I have to say, you need to take Advil for it. Take it for 3 days, and then usually it makes a huge. Now, if they keep coming back to that, then you have problems. And I never take, I mean, I take Advil like once a year, and it's amazing. It's like a wonder. It's incredible. So I never take it. You sure your needles in?
Oh, my needles are out now.
Yeah, okay. Anyway, honestly, all of these nutrients are helpful, but I would really, and the snow salt thing, I don't know. Low oxalic, that makes sense. I really think getting people off sugar and bad fats is good. Dance around it all you want, but if they're eating that stuff every day, drinking soda pop, eating French fries, fried cheese curds, things of that nature, you're not going to fix these. Maybe you guys will, but I don't. So these are muscles that, when you're thinking about a strain situation in the neck, like we saw with several of you guys been in Rex, these are the muscles you always want to think about. Levator, neck extensors, platysma, we haven't talked about that, but sometimes that can actually get injured in whiplash. They get this weird stretch, and the platysma will actually get its proprioception will get thrown. Easy to check. You can just go up and stretch it different ways, like you would, like checking skin. Remember, look how many nerves are coming out of this neck. So when we go up and we're grabbing people's necks and we're adjusting, look how much neurology we're touching. And it's massive nerves that are right there. So we need to be really respectful and careful. This is the most vulnerable place in the body. Why wild animals will go for the throat. They're going to get their biggest return on their investment. Our weak link. And that's why when we're emotionally fearful or we're emotionally, what do? We lock up here. Throat chakra. So all of the muscles, you go back to session 1 or 2, spindle up, spindle down, O&I, GTO. Don't ever forget to go back to those bases, because that will fix more stuff than anything. So this is a quick review. Weak muscle, origin, insertion, GTO, spindle cell. The nutrition, this may be on your test, is phosphatase enzyme. That's especially with regards to the neck. Just make a note of that. Strain, counter strain, Wally always says folic acid. Fascial floss, B12. That's the classic nutrition for those kinds of muscle conditions. If somebody needs a lot of effleurage and lymphatic drainage, give them some B12 or testimony. Folic acid, you guys are more aware of this than I am. There's so much more knowledge now about things with the methylation and all that, which we never knew about that here. So I don't think there's any reason to use any B vitamins that aren't methylated and phosphorylated. It makes no sense to use any that the body has to go to extra work to. So everybody should be getting the special methylated folate. So yeah, remember this for, this may very well be. Whiplash, we were talking a little bit about this. Well, remember plus? Remember plus? That's something to think about with car wreck folks. Hyoid, did we talk about hyoid in the class? I don't think we did. TMJ's next session. Aaron, would you mind coming up again? I'm going to show you guys how to evaluate the hyoid. I have slides on the hyoid. I think it might be next session. I think I teach it along with you. The hyoid has a whole, I think it's 12 muscles attached to the hyoid. The hyoid sits there, it's not attached to any other bone. It's the only bone in the body that's free floating, suspended by muscle. It's basically like a gyroscope. It serves the role of providing attachment points for the anterior neck muscles and the throat muscles. But it's also involved in balance. So some would suggest that its purpose is more proprioceptive than anything, than actually biomechanical. So what I do is I find a strong indicator muscle, I gently, very gently, push your hyoid to the left. We had that turned on, didn't we? So that's one more. Go on. I'm using it as an indicator muscle. I shift her hyoid and she goes weak. What's that tell me? Muscles on this side are hypertonic. Now it's hard to spindle up the hyoid muscles, and we'll go over them, but because they're so thin and they're but usually what we do is on the tight side, go in and you just try to spindle down. And the muscles go from the skull down to the hyoid, and from the below the chin down to the hyoid. Okay. And I'm trying not to get on the thigh right above. And then from the hyoid down to the sternum.
So you're spindling those down.
I'm spindling them down. First, I kind of wake them up, and then those muscles will adjust to torted neck postural position. So that I cleared that. Now I'm going to pull it forward. Be very gentle when you do this. I'm going to pull it forward, and I'll push it gently back. So when you push it back, you're stretching these muscles here, the digastric and the mylohyoid. So I'll go in there, and it's hard to spindle these down, so I'm just going to push into the middle of the muscle to create a stretch. See if I can calm it down. Like we do with the TMJ muscles. You can't get in there and spindle them, you have to just do the best. Now, there are people with a lot of scaling issues, hyoid, neck stuff. I give them neck exercises. Depending on where they're at, a lot of times start with isometrics. And you guys, I'm sure, know a lot of those. Basically, isometrics like this. And you make sure they're doing it like this and not like this. And then they put a towel here and this really basic stuff. Have them hold for 8 to 10 seconds, relax, hold for 8 to 10 seconds. Then I'll have them do side. So front, back, side. Then I'll have them do rotations where they come over and they hold at the end range about 8 to 10 seconds. They're not really forcing the neck over, they're just using these intrinsic muscles to turn as far as they can and hold. Slowly go. Those are really effective. If they do those every day, which they usually don't, they'll do in the first week. And then, so just front, back, side, side. You're waking up those pathways without having them go into extreme flexion. Thank you. Thought you might have that because you had,
Someone actually worked on my highlight last quarter. This, like, Crane April, they did a piece.
cool, okay,
So.
good. We're on to your highlight. Okay, so one more thing I want to show you before we, okay, so someone else. Did anybody get, not you, because I mean, we did stuff already. Someone already adjusted, did we adjust your neck?
No, you haven't done the anchor. Well, we did the C5,
We did, that's right, okay.
Yep. but not the
Have you
oxygen.
had your upper? Not this time. Lay here. This is a thing called rocker motion. And it's, there's two parts to it. There's what they call occiput. This is in your notes. Occiput on atlas and atlas on occiput. First, what we're going to do is occiput on atlas. And that's where you have, find a strong indicator muscle. We'll use the glute med. I'm going to ask you to flex your neck, keeping your head on the table. Keep your jaw relaxed. Or just your neck. And that's strong. Okay, now I'm going to ask you to extend, keeping your. And that's okay. So the way to treat that then is I'm going to have you try to arch back while I resist. And do it again. Now arch your neck back. So that cleared that part. That's all you do is you have them try to do the motion while you resist it. Now the second part of it is atlas on occiput. And for that, you have the patient tuck the chin and lift the head off the table. Test for weakening. Doesn't have that. Then you have them do that just a hair. Just a hair. Now you're gonna lift your chin, arch your neck back. There you go. So that is, now with this one, it's passive. The other one is active. The patient is active, resist them. But this one, you simply move them into the motion 3 or 4 times. And what this does, somehow it resets. It's a very general approach with arching neck. Yeah, so that cleared that. So that's rocker motion. It was on this list. I wanted to introduce that along with highlight. And we'll go over the highlight muscles next time. And rocker motion goes along with another set of protocols called pitch, roll, yaw, and tilt. And we were going to do it this session, but I don't want to do it this session. Too many. Thank you. So the rocker, a lot of times if you don't, not sure what to do with an upper neck person, you can do that very safely. Just have them tuck, test, then test, and then off the table. For the one where their head doesn't leave the table is occiput. Top down occiput, C1 is how I remember it. Occiput is to clear that, you use a resistant with atlas on occiput, you use passive mobilization. They're passive. TMJ we'll get into next session, unfortunately. Okay, so this is another list of things to kind of go over. Some of these we haven't learned yet. A few of them we haven't learned yet. TMJ. We've done feet. Did pulse points. We did retrograde, remember that one? Sessions ago. We put people feet up above head and we tested pec minors, remember that? Pec's mainly a pec minor issue. Has to do with lymphatic drainage. TMJ we'll do next session. Retrograde is ileocecal valve, you guys remember that? ICV, open and closed. How do you find an ICV? Yeah. What if you had yeah, TL? But why would you TL it? Would you TL it? What would make you suspect that maybe you have an ICV? Make you want TL it?
Back pain. Back pain.
You could have back pain. You could have shoulder pain, especially on the right. Tendonitis, a lot of times on the right, is ICD. You could have, they could be bloaty and gassy. They could be not feeling well. Yeah, they could kind of smell funny. Sometimes they smell kind of gnarly when their ICD is really. There's a lot of things that would point you in that direction. Now, if you're dealing with, say, iliacus or psoas or any kind of hip pelvic stuff, and those you're finding muscles weak there, it takes a half a second to have them TL the ICV. While you're TLing all kinds of stuff, go right to that ICV, just like you go right to have them take a breath in to see if cranials might be in. You're a lot of scanning you can do once you get used to kind of putting. But it's real quick to go right to that ICV. It's real quick to go right to Riddler's point. I mean, we did stomachs, didn't we? Did we do stomach?
Yeah.
Idle hernia?
Yeah.
Yeah. So Riddler's point, which we talked about, that one that is really good indicator for HCl deficiency. Riddler's point takes a second. ICV, Riddler's, you can spleen 21, liver, Chapman. I mean, there's just all these things you can go bang, bang, bang and see what comes up while you're trying to figure out what is making you stabilize your muscles not work so well. Just as an example. Talked about adrenals. We've done category 2, 3, and 1. ICV, Fright, we will cover next time. Ocular lock. Emotions, you guys love emotions, right? Upper gate, lower gate, that was like session 1. Upper gate. What's this upper trap do? I'm in this position. What's this upper? Does it strengthen or weaken? You hear the right answer. It weakens, turns off, inhibits. Did you say that?
Yeah,
Yeah.
but not confidently, because I
Yeah,
remember
I
the
was
lat
like,
has to be on, so that would be strong.
Okay, so what happens to my, sorry, I'm just kidding. What happens to, okay, this weakens, what happens to my SCMs? What happens to this SCM? This SCM? This SCM stretches. So this SCM should turn off. If this SCM turns off and this one turns on, it allows my head to do that. Vice versa this way. When I'm in gait, my shoulders move underneath. So relative to my shoulders, my head is turning this way. So this SCM has to facilitate. This one has to turn off. So the right upper trap, in right forward gait, the right upper trap weakens, left SCM weakens, my left lat weakens to allow this arm to come forward. My right pec weakens, inhibits to allow this position. Go on and on and on. This piriformis inhibits to allow my leg to come forward. This psoas has to inhibit to allow this leg to go back. It goes on and on. But the main ones we focus on to test it is going to be upper trap. Those are the main ones we test in gait. So Just this is all reviewed, right?
Yep.
Upper gate, lower gate, we test it all together. Now, you can test gate, you say, well, okay, so in this position, my right piriformis turns off. How do you test that? Well, you can put somebody up against the wall and have them stimulate it, and that'll repeat it. This is really good for athletes. That along with the cross crawl thing like we did last time. What else have we done? Fixations, including limbic. Plus, do you remember that one? Patient seated, from 4 to 30 degrees, the right piriformis should turn off. If it doesn't, then you start TLing to where the dura attaches. Sacrum, pelvis, lower lumbars, and upper cervical is creepy. Those two areas are where you start looking first. But it could be ICD, or it could be diaphragm, it could be any number of things, but those are you'll usually find it in those first two places. Deep tendon reflex, do you remember that one? I threw that in there really quick. Deep tendon reflex is where you, somebody got here with it, tendon reflex. Anyway, somebody that has typically good. No, not that. Anybody, I won't hurt you, I promise. And we don't have a reflex one. Anyone have one in their briefcase?
No,
Mine's my car.
of course.
So, lay it back. This is deep tendon reflex. We did this one of the sessions. So when, push up. Okay. When you trigger push up, pull back and pull. So when I activate this deep tendon reflex on Tella, just triggering her quads, quadricep, proprioceptive reflexes, and immediately test the antagonist, the hamstrings, they should turn off one. It's a normal response. If they turn off and keep turning off, then you got to start looking for what's disrupting that feedback. Also, if I tap this reflex and test this opposite quad, it will go weak. So it's a phenomenon that, it's one of those weird phenomenons that's the normal thing that should happen. Doesn't, kind of like plus, normally that right piriformis should turn off. So let's just see if I can get, so I'm just going to do, here we go. Now pull back. Back. Yeah, so that's a weakened once. Same thing here. Shut. Kick it. Oh. Kick it. Okay. So if I do this, push up. That should weaken. And push, push. Actually, there's something going on with that one because it wants to stay weak. Let's just go into that. You been running or lifting weights or anything? I had a patient years ago. He came in and he said to me, he said, "Doc, I feel like I've been working out, but I swear I haven't." In case I was suspecting that he was working out again. But it just cracked me up the way he said, "I swear I haven't." Like a patient that kept complaining about his neck, his shoulder, because he'd be sitting there watching. Okay, yeah, there's some. You might dig into that. I won't right now. He's sitting there. He tells me this. I just saw him the other day. I hadn't seen him in like 4 years. He's in his 80s now. But he told me one time. He said, "Yeah, this hug on neck and shoulder." Like when the wife and I are watching, he calls his wife the wife. Her name's Joyce, but he calls or the wife, they sitting in their recliners, and the wife always has this bowl of M&Ms sitting there. She has it sitting too far. She says, and I was reaching for those M&Ms, and I kept feeling that pain, you know? And I'm thinking, you have no idea how much you're telling me. You're sitting there eating freaking M&Ms all evening, watching whatever, and then you're wondering why you're inflamed. And it's like, but in his mind, M&Ms had nothing to do with it. Could have been reaching for anything else, right? But anyway, it just cracks me up. Every time I see him, he's just a wonderful guy. Every time I see him, I kind of chuckle from. He's not doing too good. He's probably not going to be around all that much longer. But, anyway, where were we? I think we covered everything here that we want. Anyway, review all this stuff in all your abundance of spare time. I know you got ocular lockdown. Seems like everybody's got that one figured out pretty good. What else? Oh, that's it. Okay. So, what we have. So I need to blast out of here right at 4:30. I have a flight at 5 something.
That's like
6. It's just before 6. 5:30. Yeah. So that should be enough time, right?
I don't know.
Did you have a check? Are you checking a bag? Oh, okay.
I don't know what the TSA these days.
Are you checking?
You should have showed up this morning.
Why? Why is that?
Yeah.
I think it's at 5:45. It's the last. It's the one I usually take, and it seems to have no problem. But then again,
I just flew to Oregon. I said I had no problem.
yeah, I have no problem coming down. No problem. Went right through. Yeah, no problem. But yeah, I'm not too concerned. I just want to make. If I leave at 5, that might be a little.
That would be pushing
It's always busy there on a Sunday evening. Anyway.
If you do get into it, all the terminals, the one security line is long.
Oh, good. That's good to know.
That one's pro.
What's that? I have clear. Oh, yeah, I have clear.
You're fine.
And they tried to talk to me. The other day, you can get clear can set up TSA for you. But I have it's like $80. So thinking about that. But clear's pretty good. They just take it in front of the line. You're like it's like you're special or something.
It works.
If you have to leave at 4:30, should we do the
So
sheets?
here's what we can do. We got basically an hour. How much do you guys want to go? You want me to throw you a few practice questions? And then, do you want to run through the new shoulder muscles? Is it important that you guys experience? I want to make sure everybody got these new shoulder muscles. Let me get my computer out here.
Oh, Dr. Dobby, by the way, the small distance threes become.
Oh, okay.
So that works out.
Oh, yeah. Oh, cool. Cool.
Just for also when you use it in clinic,
Yes.
you know,
Yeah, that's good to know because I honestly didn't know
like neck and occiput headaches is what it's known for.
that. Small intestine 3, which
There's main point of occiput neck. So, which is what started all of the
You need a chair?
oh, the batteries. God, it's gone. Always something, you know?
Oh, your juice bottle.
Yeah.
Got everything plugged in, just not.
Not in the right stuff, yeah. Thanks. Gotta have my things charged up so I can entertain myself on the plane with words of wonder.
Well, you need. Mine is all caught up until this weekend and I forgot mine, so.
So this might take a second to
What do you need?
Do lie down. Okay, don't do that then. Burn it. Just, yeah. You say breathing makes you moving.
I mean,
She's like, well, maybe. That's all. Just don't be moving right now.
you need to go in there for contrast hydro.
Yeah, so 557.
Yeah, she don't like that.
Oh, that's right, you're diabetic.
Yeah, she doesn't like that.
And I probably have hella toxic though. So sometimes they just need to stay in your travels.
You could do, what am I trying to say, castor oil packs. You could do vitamin C. I'm sure your liver hates you. Glutathione.
Okay, you guys ready? If I had power out there, I could come out. Actually, would you guys mind gathering in? Because that roar and I got to plug in right now. It's coming in closer.
What do we do?
Give me some, yeah. Come forward, gather around. Now, this will make some of these questions might make some of you really nervous. Now, it makes me nervous if nobody knows what I'm talking about, because any of that probably didn't cover it. So, I'll throw you a couple of weird ones. So, we talked about little embedded programs. First session. And my recommendation is if you have print out or slides or whatever with chapter reflexes, the one that's in the slide, and it's also comes right out of Google. Have that handy, because after a while you memorize the ones you use on. So here's the question. Well, neurolymphatic reflexes were discovered by A. Bennett, B. Desjardins, C. Chapman, D. Sato, E. DeBoer. C. Chapman. We call them Chapman reflexes. But Desjardins Desjardins has a lot to do with category 2. So let's see. Now, which of the following meridians is represented on the pulse points on the right wrist? A. Small intestine. B. Bladder. C. Kidney. D. Stomach. E. Liver. Oh, here's good. So, which respiratory pattern characterizes the glabella EOP cranial plug? We also call it EOP. Which respiratory pattern characterizes the glabella EOP? A. Weak on half inspiration. B. Weak on inspiration, strong on expiration. C. Weak on inspiration through one nostril, strong through the other. D. Weak on oral or nasal inspiration, but not both. E. No respiratory pattern. So, oral or nasal, but not both. Now, the one nostril one has to do with a thing called ionization. That's in the people. So, let's see. How's it? Is that? It's a pretty easy. Okay, here we go. The rectus femoris tests one. Stretch the muscle remains strong. You conclude A, this is a normal muscle. B, the muscle needs strength counter strength. C, the muscle should not be relied on for chatter. D, this muscle needs fascial release. Or E, this muscle needs treatment of bulging tendons. Okay, it's a normal muscle. Muscle shouldn't weaken to a stretch unless it's got fascial flesh. That's the signature response to the fascial flesh. It's strong in the clear, weakens after a push. Well, it's using it. It's not able to offload its excellent, so that it's sort of it needs it's too much stagnant chi and too much stagnant stuff. It will now the other way I do fascial flush, but a lot of times I use especially demonstrated videos. I think that actually the fascial flush along with PNF. Because then you reset PNF helps reset the proprioception. But the fascial flush some reason just too easy. Okay, this is kind of fresh. So tarsal tunnel, this is I think last session. Tarsal tunnel syndrome can result in which syndrome? Syndrome A, median nerve seizure. Tarsal tunnel. B, open illegal secret. C, excessive supination. D, retrograde sciatica. Or E, hallux rigidus. Nobody knows. Actually, Carpal's tunnel syndrome will often be associated with and shoulder issues, but no, it's hallux rigidus. So you remember tarsal tunnel syndrome? It interferes with the nerve supply to the intrinsics. So the long hallux flexor hallucis, the longest, gets its innervation north of the tarsal tunnel. Intrinsic, the brevis, gets its innervation south of the tunnel. So if there's interference with that nerve, you lose the strength of the brevis, maintain the longest, which puts a weird pull on the hallux. So that's the best answer. Let's see. Oh, getting two. It's only 100. Oh, rectus femoris is associated with A, ovaries, testes, B, uterus, prostate, C, small intestine, D, large intestine, E, stomach. Rectus femoris. Small intestine. All quads, abdominal, small intestine. What about adductors? Ovaries, testes. Okay. So, yeah. Okay, so remember, nobody should get that one wrong. If this, I have 3 different tests. I'll probably give you one. But they're all. Here we go. This one might be. This may or may not have covered this well enough. Which nutritional supplement is used if a patient's sartorius weakens only in the dark? So the answers are as follows: chlorophyll and concentrate, vitamin D, pineal extract, adrenal extract, vitamin A. So I didn't go over that. I don't think well enough for it all this time, but that's it's probably in your notes. I know it's. So Dr. Goodhart found that sartorius would be strong, which is related to adrenals. But if you turn the light on, it'll be. So he somehow determined that ideal stuff. A lot of the stuff is very historic. It goes back to the early discoveries in AA and it got into the literature, and now it's sort of the gospel. So. Oh God. I heard the story, actually. He told me stories over and over again. What's the story? Somehow, I can't remember how, somehow he ended up turning the light way down. He had all these serendipitous discoveries that were just amazing. The guy was amazing.
What were they doing when they thought of this?
I thought of what?
The priorities.
Yeah, well, you know, there was a Dr. Beardo. Dr. Beardo, who was actually in he was one of Dr. Jordan's early students. He was a mad scientist, and he went off and he came up with all kinds of stuff beyond what he's been years. Unfortunately, he died a long time ago. There's still people that use his work. It's called clinical physiology. He's the one that came up with all these modes. And the hand modes determine all the I've never been to them. But Dr. Sheldon Deal, who's just down the road, he came up with this particular word. This comes out of the word. Beardall has all kinds of things. Muscle testing, the idea you have this computer that's full of.
Yeah, we're gonna try to have him come in and talk.
Who?
Dr. Deal. We're gonna try to
Oh,
have him come in
yeah.
and talk, but
Yeah,
apparently,
if you could, yeah.
yeah.
Oh, yeah. He's getting pretty long.
Yeah.
He's not getting.
He's like 80 something.
He's in his 80s, and yeah, he probably would do it if he could. He's getting.
That's not happening.
But, yeah, he's getting.
I'll drive down there. He basically communicates with pigeons.
He's one of the original.
He only takes mail.
First set up ICA. First set up the educational part of the ICA.
I don't know what's gonna happen.
It wasn't actually 12, it was like 14. They all were part of this cadre that was studying at Georgia University. They all became charter students. So they call them the dirty. But these guys, there's only a handful of them. Sheldon's one. And yeah, most of them are gone. But yeah, the dirty dozen. And they were like the original apostles. George was like Jesus. So, okay, let's do a couple more. So the way this word is complex, okay? Okay, so body memory of an injury. That pertains to IRT. So a body memory of an injury with surgery and associated subliminal withdrawal reaction may persist up to so A, 6 months, B, 2 years, C, 10 years, D, 20 years, or E, death. That's why they call it body memory. Okay, so C7 and the first rib gets a positive T. At first, nothing, and then the patient moves the area where there's a positive T. What's the condition? Okay, so the patient TLs with C7 in the first rib. Nothing changes. Already hair muscle stays strong. Patient then kind of wiggles it around. Also goes
Fixation. Yeah, fixation.
limbic fixation. Limbic fixation. So know those fixations. Know them for the test, but know them for yourself. Know these. That's fun. You get into practice. You don't have time go back to your note, what was that he talking about? No, that's not cold. So where did I put that? Can't find that. I kept all of my notes from chiropractic college for about 17 years. I had them in boxes. Every note I took, what the heck? I always thought I can't throw this away. There's all kinds of get in there. I never looked at them once. I finally had to clean out my garage. I needed more space, and I had them. That was, of course, we didn't have any computers. All stone tablets, scratches. A recurrent shoulder dislocation usually involves laxity of which muscle? Now, this isn't so much AK, this is just kind of standard. The A, teres minor, B, infraspinatus, C, subscapularis, D, subclavius, or E, supraspinatus. Recurrent shoulder dislocation usually involves laxity of which muscle? It's usually it's a it could be, honestly, it's not a very fair question because it could be the subscap too. I'm pretty sure the answer is pretty sure that's the answer. What I do is if everybody has a problem understanding, or say most have a problem understanding one of these questions and it doesn't make sense, and there are a few in here, I will take that question. There's, I mean, it's kind of like know the TS line. Just get a picture of it, have it handy, just feel it on yourself. Get used to, kind of this is T12, 11, 10, 9. And then you've got L1, 2, 3, 4, 5, T1, 2, 3, 4. Actually, not on your chart, but 8 is right. That's on the actual chart that teachers study it from MLBs, but just memorize it. Lower thoracics, lumbars, T1. There's no cervicals. Yeah, in the slide, there's a couple of things.
I meant for like the example.
Oh, what? Pictures. I think there's one thing where you gotta do some matching. Some of the old exams have pictures. I don't think there's any picture. But yeah, if you have trouble, you can always draw them. If you have trouble. Let's do some of this we haven't really covered yet. Okay, what dietary advice is given to a patient with cerebral palsy? A, increased roughage in the diet. B, drink alcohol daily in moderation. C, increase raw foods. D, avoid spicy, rough, or irritating foods. Or E, go on a liquid diet. Avoid spicy. So spicy foods, chocolate, caffeine, alcohol, nuts, seeds, chips. Spicy foods, chocolate. So all the things we love. Remember, if you eat popcorn and you get those little burnt husky things and they cut your mouth, those are the same thing as your gut. Your gut's not even as tough as your mouth. So any questions? Besides, what do I need to study? Any questions? I mean, we got 2 more months. Some of this, well, oh, here's a true false. Okay. Good. This is a good one. Number fixations. how many vertebrae fixations? Three or more. What about subluxation? They act alone. So, true or false? You have determined that there is an anterior fixation. You would adjust the top and middle vertebrae of the three flexion. You have determined that there is an anterior fixation. You would adjust the top and middle vertebrae of the group that are in fixation. True or false? If it's an anterior fixation, remember you find the fixation. By the top of it, feels like, okay, it's kind of stuck, and now it's kind of not so stuck. Go down here, it's kind of stuck. Oh, not so stuck. That's you find it there. Then you go right, left with the spinous processes, and one side will be kind of stuck. The other side, not so much. Then you go out to the TP. So say it's stuck and it doesn't want to go this way. And you go to the TP and it's stuck on this side. No, I'm sorry, it's stuck on this side. That's an anterior fixation. You go to the bottom, opposite. You go to the, don't go in for your anterior. You go on the opposite side and you adjust from the bottom away from the, it's a posterior fixation. You go from the top, adjust the bottom away. Now, there's not that much difference, really, but the key is you want to know if the vertebrae is, if it's moving this way but not that way, that fixation, if the fixation is that it won't go that way is here, that means it's anterior. You don't want to do this. If it doesn't want to go this way and the fixation is here, you want this to go from here. Okay. So that's a posterior fixation. So the answer to that is false. Oh, there's some matching. Okay, know your fixations. What's the cervical thoracic fixation show with bilateral muscle? CT junction. Bilateral muscle weakness. Cervical thoracic. We did that with fixations a couple of months ago. Cervical thoracic is, CT junction. Oh, right, yeah, that's right. That was the occipital fixation. Is that what you're asking? Did today? We had a bilateral psoas, that was the occipital.
Oh, that trap. We had something else.
We had a bilateral upper tract on you. Yeah. Yeah, don't see that too. Okay, so cervical thoracic is going to be bilateral. Bilateral lower trapezius weakness would be what kind of fixation?
Lumbar?
Because think about where it attaches. Lower tract attaches way down here to the thoracic lumbar. But there's a fixation there, it messes up the muscle. That's how. So cervical thoracic is going to affect the deltoids straight up. Usually, the ones that aren't so straightforward are like the bilateral psoas being due to the occipital fixation. That takes more imagination to get your head around. Upper cervical fixation, what does that cause? What bilateral muscle weakness?
Glute max.
Wow, who said that?
Glute max.
You remember that from last time we did it?
You said it earlier.
So, thoracolumbar is going to be lower tract. Cervical thoracic is going to be dealt with. What about single neck extensor? So you're strong here, but you're weak over here in the neck extensor. What kind of fixation? Very close. Dominant. So a weakness on this side would be iliac. It'd be the iliac. Ilium on the right. Could be a PI. Usually a PI. Psoas is occiput. Glute max is upper cervical. That's all we got. So when you review your muscles, review your the neurology. Just take a quick glance at, like, pretty much everything in the shoulder and arm are going to be C5, 6, and maybe 7, 8 clear down here. Pretty much C5 to everything, all the leg muscles above the knee are going to be lumbar plexus. Everything, basically below the knee is going to be sacral plexus. Sciatic nerves. Sciatic nerve doesn't really innervate anything until it gets clear down. Just travel, it's just passing through. You guys familiar with lateral femoral nerve entrapment syndrome? It is, so it's not uncommon, and you see it a lot. I seem to see it a lot in older men for some reason. It can be a really troubling condition. They can hardly walk. It's a problem with the TFL. TFL entraps the lateral femoral continuous nerve. There usually isn't any significant motor effects. It's all pain, sensory, but that cutaneous nerve gets trapped and gets really hot, and every movement is painful. You get in and you spindle up and you fascially flush and you just dig the heck out of that TFL. And you get to, usually it'll be weeks if they'll let you test it. You get in there and you start flushing it, pressing it, spindling up, and if you can get that muscle to turn back on again, it'll get rid of its own congestion, start allowing that function. Those are pretty common. And I often see them, they've been going on months and nobody's tested their TFL. Stuck needles in it, and they massaged it, and they've given them lots of drugs, and that needles like steroids and whatnot. And nobody's tested that muscle, or even looked at their pelvis, or how the rest of those muscles are. A hypertonic TFL is, the TFL is a slightly internal rotator, abductor, slight flexor. It's also antagonistic to the nerve. So when you have a weak piriformis, got a potential for TFL being nerve. Same with the hypertonic pec minor. Hypertonic pec minor will crowd the brachial plexus and the lymph channels. Hypotonic pec minor will, which I find pretty common, but like we were talking about earlier, it'll allow this clavicle to slide back too far and create ischemia. So brachial plexus problems, honestly, they used to scare the hell out of me when I was first in practice. Now they come in and go, oh, good. Oh, it's just, don't worry, it's just a brachial. Flippant about it, but it's, I actually find them challenging. There was a time when they just scared me. Same with shoulders. Hot shoulders. But I put a electrostim on them and ultrasound them and do all these things I, trained to do, and try not to move it too much because that's what we're talking about. And we have, we still have quite a bit of time. So we got about 40 minutes. You guys want to run through the shoulder muscles? You want to do some, let's see if you can do some more integrated stuff.
More questions.
One question?
More questions.
More questions?
The ones that back there.
More questions? You want to ask questions? What? Who said what? Nobody back.
I think they ran off.
Yeah, they're being silly.
Yeah, she just wants more of the exam questions.
Oh, more exam questions.
Like someone's, yeah.
How much did we give you for the whole exam?
How much? I was the airport at the time. I see shoulder muscles. Shoulder muscles.
It would take a lot. Like more than that.
So there's special selects.
I'm not even sure, unless some of you are wealthier than students typically are. I don't know. We'll have to see. You come up with a number. Throw something. I mean, this is the era of Trump, right? Everything's for sale. Everything has to be. No, so we'll do a couple more, right? But I'd like it if you guys, I would love it if you guys could maybe, I'd like to teach you a little and be able to work. Okay, so we haven't done this yet because it's next to, but see if we try this one. Nutritional support for aerobic muscle testing. Now, next session we have a thing where we'll do aerobic and anaerobic testing. I don't do this a lot because it's going to cover some topics, but it's a great thing. These are full method. It's a well-known athletic trainer and nutritional support for aerobic muscle testing. Now, aerobic muscle testing is where you test its so nutritional support is as follows: A, 12, B, magnesium, C, manganese, D, iron, E. Correct answer is all of those things. Think about it. Oxygen. You guys won't remember these. They'll be fresh. Okay, what? Oh, this is too easy. Okay. True or false? The piriformis muscle is associated with the lung. I heard it was on false. What is the piriformis muscle? Somebody said laugh. Oh. Which muscle is not part of the rotator cuff? A, subclavius. B, subscapularis. C, infraspinalis. D, supraspinalis. E, teres minor. Subclavius. I like that. More of those, please. Okay, I'll give you. Oh, this one, this one could be. Okay, which organs are most involved in maintaining a normal blood sugar level? Organs involved in maintaining blood sugar. Okay. A, heart, stomach, small intestine. B, spleen, liver, kidney. C, adrenal, pancreas, liver. D, thyroid, adrenal, pituitary. E, pituitary, gonads, liver. Not exactly that straightforward. So, C, adrenal, pancreas, liver. Adrenals, cortisol, pancreas, insulin, liver, stores glycogen. The earth element is considered to be the mother of which element? Earth is the mother of matter. Next, session 7, we do the 5%er. And a bunch of stuff we use to share. So we have. So how do you feel? Feel like you take this next? 2 months, yes. 2 months. Just pick little bites of it, and just kind of feel like you keep things. Don't get fancy. Just stay with that list that we had up there a little bit ago. That, except for the things we haven't covered yet. Just go back to your notes and just make a list of every topic, and then know that. Bit by bit, you'll go back and review it. That's a good one.
First hour, we write March, since we skipped March, we did not write them.
We didn't have March was not.
Right.
Just go by session. March would have been session 5, but this is not session.
Okay, just the amount of hours I know was, we have exactly the calculated hours. We're going into June.
We're going into June.
Oh, we never supposed to go into June?
No, we were going to be done at that.
Oh.
This would have been session 6.
Okay, I thought we always were supposed to.
Okay, well, no, we are now. In fact, it seems like there's not June. It's June 6th, 6th and 7th, I think.
Yeah,
it's the first. Well, what I would like. Okay, so the written exam will take Saturday. Towards the end of the class on the 6th, or whatever that Saturday is, we'll take the written exam Saturday, we'll take the last hour and hours. So you guys are really worn out. I mean, and that way I can grade them for that exam. And then Sunday, do whatever you want.
What happens if
I'd like to do the practical next session, and like say the Saturday or Sunday of next session. I'd like to do that. That's agreeable.
what happens if you can't, if you've got something that weekend or something? Like you're unable to come.
Which weekend?
June 6th and 7th, the weekend of the practical.
I don't know. That's an interesting question. Can you not make it?
Oh, I can. I was just asking just in general.
I mean, we can make some. I don't know. I don't have like a contingent plan, but if somebody has the hours and wants to take it, we can figure out a way. But the practical, if you guys are.
I know you said that we can retake it as many times as we need to. You have to retake the course, or like let's say we fail it this first time, we reach out to you, still retake it, like without retaking the entire course.
Yeah. I took my diplomate. Well, I took my diplomate test. There's 5 exams. Just a bad. They're really. And I took all 5 in this one conference in New Jersey in 2015, and I failed 2 of them. And if you fail 2, you can retake just those 2. If you fail 3, you got to take them all. So fortunately, I just had to retake the 2, and I took them. The next year in LA. and passed it. And then I took my diplomate in the fall of '05 and failed it. Took my diplomate practically, and I failed it. And they failed. And I was pissed. I was so pissed. And I really sucked. I mean, I was jet lagged when I took it. I wasn't prepared. I went in there just sucked. I deserved to fail, but I was still pissed. And then I went back 2 months later. One of the IDC diplomates was going to be in LA doing a agreed to do tech review for a couple of us. And that time I just nailed it. I just nailed it. I was like, I was Judy ready. And the other guy that went through with me was his first time. They failed him. And I won't tell you who it is because he's a very prominent character in ICK now. But he just came in there all cocky, hadn't really prepared. And thought he had, but they asked him that he didn't know how to do he didn't know how to do a stomach correction, and he didn't know how to test Popliteus. And it's like, and he was kind of cocky, like, well, I don't do a lot of the old stuff. And they failed his ass. And he came back the next year and he passed it with flying color. He knew that. Yeah, so the diplomate, they take the diplomats seriously. So those of us that make it through and become diplomats, it's kind of cocky, somehow. And they don't, I've never had any of my own students. That would be something I'd love to have happen. That's why I was working on Dr. Whitney. I think she really wants to take her. She's totally had enough background to do it. I think I think she wants to teach. There's a part of her that wants.
She's good at it.
She is. Yeah, she's a natural, and she should do it. She will. Anyway, so the practical is like I could take 2 of you guys at a time and say, I want you to check your patient's posture, and I want you to test the muscles that you assume might be weak. And then if you do it really well, then I'll ask you more questions like, okay, so what is that muscle? What organ is that muscle? Where's the alarm point? What condition might that muscle be? Or you know the alarm is. If you know the basics, you can pass it without, but if you seem to know it pretty good.
You're telling us to play dumb then.
What's that?
You're telling us to play dumb then.
Well, there's a break even point. I mean, you can be, you can be prepared, but not overly sharp.
He's saying dumb.
If you come across overly sharp.
He said, "Don't be ready for
overly
diplomat."
enthusiastic, I'm gonna ask you about that. Or Rachel, when Rachel went, she was one of your past AK Club presidents. She had taken it, I think, 2 or 3 times when I did the practical on her, and I wanted to see how she thought, and she actually did really well. I kept throwing, I said, what if this, this, and this, and she kind of kept working her way out of it, and so showed that she had learned how to. That's what I want to say. I want to see if you guys. Is this? I mean, the certificates all great. You can hang it on your wall and whatnot. But whether you take the stuff and really use it, that's what I want. Shall we want to run through the shoulder muscles? Do you want to treat everybody that needs to miss anything that I said? Well, we'll get to that later.
So.
How do we do it?
Something else.
On you?
Oh, did you?
Has cat 2, you have cat 1. There's that. Cranial.
Did you have any cervicals? Or did she have?
We didn't do IRT. Yeah. Is that okay?
Okay.
Body memory or would they kind of
Yeah,
go?
ground.
Are you cooking sauce, but? I don't care, but as long as you're cooking this
So,
Thought I did it. God.
Oh, just wait for that. I couldn't walk. Wait, what's oh, they're starting cardiac first? Yeah, I have Axel prep, I have geriatric discussion, geriatric video.
Yeah.
I have oncology.
Kirsten's gonna wanna hang out.
You didn't do like a.
Give me.
Well, now I'm done. Because you can see he'll let you. That's fine. What do you have? Are you trying to get certified? Is that what you said? I don't know if I can do certification. Yeah. Right? Sounds like you can't do that. Yeah, that's true. That's very true. Yeah, that's also true. Travel more in the future.
we got to adjust.
He's pushing her outward.
So you spindled up.
Yeah.
Yeah. February 21st and 22nd session 4.
So we checked IRT over here.
It was what?
Right down here.
Well, that's really confusing. It's a session 4.
I want you guys' attention for just a second. Just hold your thoughts there for a second. Because I want to, what we didn't finish with Jennifer was IRT. So she's had, you had the car injury, the neck thing. But you also had an injury last year to your sacrum.
Yeah.
From an adjustment, chiropractic adjustment of some kind.
I was gonna say.
Okay. Which was very debilitating. So what we found, we came back here because a lot of her stuff is kind of cleared up, but she has now weak scalenes on them. And they were weak on the left before. So now we got a new thing. I tried doing IRT or checking for IRT in the neck and nothing. I tried spindling up the scalenes. They didn't spindle up. I go down and I stimulate the area around where she had the injury from the adjustment. And she strengthens. So she's got IRT. I said, you haven't had IRT, you haven't had it done.
No.
You weren't in my class last year. No. So we're going to fix, that's in the lower part of the body, so we're going to use the tower tilt, lay on your back. Now, it'd be really fun to go on to see if there's anything else related to this, but for now, we'll just, so eyes down and to the right. We're going to check sacrum on the right. So that tests too. So she's got an actual, like, besides the IRT. But what led me to IRT was, number one, her history, but also the fact that these scalenes wouldn't spindle, didn't respond to spindle up. That's your go-to move. When a weak muscle doesn't spindle up temporarily, you want to suspect IRT. So first thing I'm going to do is I'm going to stimulate this area, and I'm going to do IRT, and then we're going to see if the subluxation still wants to show itself or whatever.
Doesn't indicate hyper failure of spindle.
It was weak in the clear. It wouldn't spindle up and strong. And now, there could be, if I could find a hypertonic muscle, I'd have to test for one that is, that's strong and clear and then weakens to a quick stretch. And I could see if it autogenically fits. That would also be an indicator of IRT. And if it didn't turn down, let's say, for example, her quad quad's strong, but say we gave it a push, it's still strong, but say it weakened, that would be a hypertonic muscle. And then I would go, okay, I would spindle down this way, and now normally that should turn off the muscle, and it does. But with a hypertonic muscle, it will not. And if it didn't work, this is not a great example because it's, but if this was hypertonic and it didn't spindle, didn't inhibit with my spindling down, that would be iron. Usually weak muscle doesn't turn on to spindle up. That's your go-to. Dr. Wally Schmidt still has, he's been gone for several years now, but there's still a website called The Uplink, which is from his practice. Tons of great information on that. And then, of course, there's the quintessential applications program that it was Wally's version of the 100-hour course. It became a 300-hour course. And that's still available to the people teaching that course. So we are going to do IRT on her sacrum. Rub, 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 poke, poke, poke. And then I'm going to flick. There we go. There we go. You want to make sure the ankle relaxes when you. That sometimes tells you that the IRT pattern is kind of working against you. So, eyes down to the right. So that cleared that. Okay, so eyes down to the left. Now, eyes straight ahead to touch the right sacrum. Okay, so that the IRT cleared that finding. Cleared that finding. Now sit up again. So, that muscle's strong now. I didn't do anything to the neck. Not this round. Just cleared the IRT. So that's how effective it can be. We'll walk around. Just go give it a little test drive and we'll see. That makes sense. You guys all followed what I did. After a while, you'll see that they most of the time work the same way every time. You got a weak muscle, just throw everything at it. Spindle it up. Have them take a deep breath in, different kinds of breath in. Have them TL the muscle itself. Have them TL the spinal level that the muscle gets its nerve supply from. Have them TL the Chapman reflex, the Bennett points. Have them TL emotions. Just take out when you find a weak muscle, just see, compile all the data you can about what affects that. Then you got to kind of sift through and see what's more important. So scalenes were the big ticket item. Still strong. I'm very happy with that. Stand up and we'll see if it's still good standing. And we had pelvic stuff. So we had a cat 2 and a cat 1. And a lot of times when you test people, that's good. I'm good with that. Always make sure your test is, I sound like a broken record. Always make sure if you test people fine, seated or standing or prone, keep testing them that way. If you change positions and you're using the same muscle, make sure you get your baseline again. Because it's so often, I can probably randomly pick one of you and test something that tests fine standing, and when you sit, if there's any kind of pelvic issue or lumbar issue, sitting will change the parameters of the test. So, and if someone spends a lot of their day sitting at a computer or driving or whatever, you want to test them sitting. Or test them standing also, but it's important to test them where they spend a lot of their time. Most people don't spend their waking days lying down on an adjusting table, which is often, for us, it's much more convenient to work on, but that's not how they live. You're not challenging their pelvis, you're not challenging anything the way gravity challenges it in their activities. Challenging their feet. So it's always good to fix them and have them at least stand up and bounce around a little bit and go for a little. Because you'll find a lot of times stuff doesn't hold. Otherwise, they're out before they get to their partner. As long as they hold, as long as they pay the, sign the check. Okay. Anything you want to review from the other sessions? Muscles. Test the shoulder muscles. Just grab your partner. You guys were already doing it. Grab somebody come up here. Maybe like meeting or something. So we're going to just grab a partner. We're going to test the shoulders. Make sure everybody's got this one down. So these, we're just going to do the new ones. Just going to do the new ones. We'll do it. Alyssa's not here, but she loves military style. We'll do military style. So everybody get behind your patient. Everybody take their right arm and elbow out to the side. Just like I do. Now, take your left hand underneath that elbow. Take your right hand, and you're just going to check that patient's range of motion before you start testing. It's got pretty nice range of motion there. That's right. And then you're going to take that arm and you're going to bring up, see how they're passive abduction. You want to know these things before you start testing. Reach that arm around in front of them. Well, with this left hand on their scapula, take this hand around in front and feel that scapula go wide. Feel it. You have your hand on the scapula, you move it around the scapula, it kind of slides outward. Now we come back to our testing position, and you're going to bring the right wrist down, keeping the elbow straight out from the shoulder. This is going to be the subscapular. Grab their right hand with your right hand, like a bro handshake kind of thing. There we go. Yeah, bro, yeah. Hold that right there. Hold there. And you're going to stabilize. See how my arm is on this brace.
Did you have to grab her with that?
They're not.
There we go.
Okay, so subscapulars. Now, from that position, bring their wrist. You have her flip around.
Only you can hold it right
Have the
here.
patient
Feel like-
face this way so you can see it. Elbow out from the shoulder, you bring the wrist back, up, like so. Now you're gonna bring that wrist up above the head. Now, you can test it from behind. Honestly, it's really good to come around in front of them, stabilize the elbow, push into my hand with the back of the wrist, pull that way. That's a really good, like, just like that. And you're really, you're checking not so much this motion, you're checking this motion. Interesting. Related to what organ? I mean, what meridian? Triple warmer.
Yes.
And it's related to the immune system. Okay, so infraspinatus. Now make sure make sure your wrist is more this way. Now you'll see it tested this way, and that's nothing wrong with that, but you'll miss them.
Yeah.
Like they could be pretty good here, but you get up here, and now the infraspinatus is going to be that's wrong. The infraspinatus is going to be brought more into play. So now we're going to take that shoulder and we're going to bring it down to, this is harder to do on with them sitting, but it's kind of like the lat. It's hard to test with them seated. But you want them just out from the body. It's going to be the supraspinatus. Maybe scoop forward. So you start at neutral and you just come out about this far with a little bit of external rotation. Muscle comes here and it comes right in there. So your vector is going to be to counter that. Mostly lateral to medial with a little bit of A to P. That's a good thing. Now, if you get up too high, you're into the lower division of the spinatus.
It goes in, like medium.
Okay, that's the supraspinatus. So we've got 3 of the 4 rotator cuff muscles. Bring the brachium into neutral. Forearm is at 90 degrees, thumb up. You're going to externally rotate the shoulder. Stabilize the elbow. I like to use a broad contact with my knuckles. Hold there. I'm just above his wrist. That's the teres minor.
Look at that.
That's pretty good.
That's a good one.
Now, if we come out here to, if I get too far out of his wrist, look what happens. I'm activating stuff here that's going to cause a false positive. So make sure you're north of that wrist crease. But not too far up, because then you get into this belly muscle, and that can be, like if I get up here, that can cause a weakness too, because it's uncomfortable. It's so brutally strong that it's hard to fake these muscles. Okay, so we've got all 4 of the rotator cuff muscles. Now, a muscle that goes from the scapula, another muscle goes from the scapula to the brachium that isn't a rotator cuff. Is what? Subclavius. We just saw that on the question, right? Bring the arm all the way up into full abduction.
The previous cross, I thought it inserted and attached into the clavicle.
Yes. What we're doing here is its job, okay, this is confusing. Its job is to take this clavicle as you abduct and kind of roll it like this. Kind of bring it into its socket, kind of like that. If it's not doing its job, this SC joint will bind a little. It'll bind, and actually if it binds too much, the brain will say, oh, too far. And you'll end up seeing blocked abduction from just this one little joint being screwed up. If that subclavius isn't moving that into its right position, it'll bind. That's one of the best kind of shoulder problems I like to see because it doesn't involve a very big structure and it's pretty easy to fix. So the way you test it is you put it into this position and hold the head like so, gently push out. You've got lots of leverage. And that one's weak. That one's good.
So then to reach subclavius, are you going to like above the clavicle or under the clavicle?
Underneath. Now to find it, so if you have a weak one, like I have a weak one here. So I'm going to take the patient's fingertips and have him just gently kind of push right up underneath the clavicle, because that's where it's at. It's kind of on the underside of it. Just hold that right there. So I'm TLing subclavius. And that kind of works, but it's not like super great. It's a little closer to the strip. There we go. There we go. Okay, so what do? What any good applied kinesiologist does, I spindle. Yeah, I get in there and I start messing with it. So I'm going to spindle it up. And the fibers run from here to here. When you look at it on an anatomical picture, it looks kind of like part of the pec. It looks a lot like part of the pec clavicula. Never even learned about this muscle until I was years out of chiropractic. Never learned this muscle. Or maybe I was asleep that day. Spindle, spindle, spindle. I'm also kind of manipulating that little SC joint, making sure it's got some motion. Yeah, that's right. These respond usually really. They're very common to find weak. They usually respond really. Remember, like I mentioned yesterday, when you see stuff like this repeatedly, go back to your gait evaluations. You know, static gait, like we were just talking about, or have your patient walk. If you have a treadmill, that's great. I don't have room for one. I wish I did. This motion, teach your patients how to walk. Teach them how to walk from their core. Have all of your patients walking this way. Okay. But it would be nice. It wouldn't be nice if humans all just kind of floated around like this. Instead of. But this is so important, the proprioception. Just a simple little thing, but.
Just let you know we have 5 minutes till 4:30.
Where does the time go? So, cortical brachiality. Should we hit that one?
A question and a comment. A, have you heard of walking pads? They're these treadmills that are smaller than the size of the table, no handles, no nothing.
Oh, I have, yeah.
No, $100. Then I wanted to know if in the next session, if we have like time like this when we're wondering like what should we do with our time, if it would be possible to see you like new patient, you don't have to intake, but a flow from start to finish as if you've never seen patient take the whole thing together. Yeah, like a protocol.
Now, all of you kind of know a little bit about your stuff now, but I'll forget my news. Way ahead of schedule. Yeah, guys, if you're on, you guys, I think already did these. But so long head tricep, the way I use it for long head tricep, you know, the classic way, push back. Tricep lateral head, a little bit more than 90 or less than 90. Tricep long head, tricep medial head.
Wait, so.
Medial head, long head, lateral head. Bicep, same starting position. Bicep, short head or as a group, and bicep, long head, or the way I like to do it, I'll go a little further out. And it's almost like what we call speeds test. It's a lot of times, when I'm done, I'll have them do like a whole kinetic chain thing.
So medial head's down here and then long head down here.
No, biceps is a group, short head. Yes. And then the classic way is bring slightly deflection and this way.
Oh.
But then what I do is I come out here. The long head.
Long exam you want for long head.
Yes, right.
Like a drill machine.
I've been trying to
Like that's why like all of a sudden when
all
it's
day, like.
Lunate.
yeah.
Okay, so work code, Oracle brachialis. The doctor's contact hand is on the web.
That's right.
We did pack minor before, right?
Yeah, if you can't find anything right. Oh yeah, it's an acid thing, and they just like.
So, okay, so we got 2 minutes. You guys, who has their time sheets? Okay, let me sign time sheets. Somebody else. I'm gonna be here.
Like patterns, so like, you know, how you're like, so like, why did